On this episode, we'll talk about a few complications the gastric bypass surgery has that the gastric sleeve doesn't. Am I saying the gastric sleeve is better than the bypass? Not necessarily. Let's get into it.
3, 2, 1.
Here we go!
All right, so the gastric bypass has quite a few complications that simply the gastric sleeve does not have, and I wanted to address those complications on this video specifically because we get these questions quite a bit to my office, to my email, from my patients, because sometimes the patients are confused because they get confused because another family member asked them, because a neighbor, because they heard someone had surgery somewhere else, and is it the same as a gastric bypass, the gastric sleeve? And I want to start off by saying they're completely two different entities. All right, so the gastric sleeve, which is what I focus on my practice, that's what I do, that's what I every single day, several times a day, I eat, sleep, dream sleeves, and that's what I do. But I wanted to put this video out there because definitely one of the reasons I decided to focus my practice on this procedure is because it does not have the complications of a bypass. All right, so, and let's start with a dumping syndrome. Dumping syndrome is one of the most common side effects a gastric bypass patient will get. And the reason being, and I'll get one of my toys here, is the gastric bypass patient, we cut out a little tiny stomach here, and then that's why it's called a bypass. We bypass part of the intestine, this part right here, the first portion of the intestine, and we connect with the intestine later down the road of the small intestine. So when the food you intake goes into the first portion of the intestine, of the new part, patients get this sensation of, very uncomfortable sensation, by the way. It's called dumping, where food dumps into the intestine and it produces sweat, tachycardia, dizziness, very, very uncomfortable sensation for patients. Who gets this? Well, gastric bypass patients get it. The vast majority of the patients that get a gastric bypass will get dumping syndrome. I'm going to make a parenthesis here because there is some dumping syndrome in some of the patients. The vast minority of the patients, I'm talking between 5-10% of sleeve patients that may get some dumping syndrome initially. So it goes away with time. But it's the first 3, 4, 6 months, patients may, 5 to 10% only, may get some dumping syndrome-like symptoms. But it doesn't go away with the gastric bypass. So that's just one symptom just to get the talk going. All right, another complication the gastric bypass patient is has a probability to develop down the road that the sleeve doesn't is developing an internal hernia. I'm not talking about an abdominal hernia. I'm not talking a hernia or a lump that you can see in your abdominal wall here. It's inside. You won't see this because what happens is when we connect in the bypass, we disconnect the small part of the new stomach to the native stomach. We disconnect that. And then there's this gap right about here, that a part of the intestine may slip in here and get caught. We call that an internal hernia. So patients that get a Roux-en-Y gastric bypass have a probability of developing an internal hernia down the road. A sleeve patient will never, ever have this probability because in the sleeve, what we do is we simply reduce the stomach size. There's no bypassing, there's no rerouting, so there's really no way to cause an internal hernia. Sleeve will never have an internal hernia like the bypass. The third complication I want to talk to you about today is a marginal ulcer. What is a marginal ulcer? Well, you have a new stomach pouch that's connected to the intestine, and right about here, the union where it unites, it's called the anastomosis. Patients are prone to have a marginal ulcer down the road, an ulcer that starts bleeding normally months down the road, years down the road. And if you smoke, that increases your chances of developing of this very hard to treat ulcer in your stomach. You don't get this with the gastric sleeve. The reason being is there is no connection with the gastric sleeve, because with the sleeve, the entrance of the stomach, it's the same one you're born with. See? Same one you're born with. The exit is the same one you're born with, same exit, and you're not rerouting again. So there is no connection. There is no connection. There's no anastomosis. There's no area for it to form a marginal ulcer. Another complication that may arise down the road in a gastric bypass patient, but not in a gastric sleeve patient, is obstruction. And let me tell you why. With this gastroduodenal anastomosis, this man-made connection between the pouch of the stomach and the intestine, this connection right here with time may scar, may be reduced in size, may cause an obstruction. And that is something you simply won't get with the gastric sleeve because there's no connection here. That may be a situation that may be acute. That means that you get a gastric bypass and right away, the next few days to weeks, you get that obstruction because it was simply, it got too swollen because the obstruction was too tight. And that is an acute situation, but this may also be caused down the road with a marginal ulcer that cures or semi gets cured, and then it creates a stricture and it creates the obstruction. Another important situation is anemia. Let's talk anemia. Anemia is way more common in the gastric bypass patient rather than the gastric sleeve by far, and that is why with the gastric bypass, it is important patients get supplements not only with B12, but also iron, folate, etc. And the reason being is, number one is we're intentionally bypassing part of the intestine. That's number one. So the absorption of nutrients is not as adequate as with the gastric sleeve since we're not rerouting or cutting intestine on the sleeve. And the other thing is B12 and the absorption of B12, and for the B12 to be absorbed in your intestine, it needs to be it bonds to an intrinsic factor that is produced in your stomach. But remember, the stomach here is detached. All right, so B12 is not correctly absorbed in patients with a gastric bypass. That's why it's very intensely supplemented in patients with the gastric bypass, and this situation does not occur as much with a gastric sleeve. Speaking of which, absorption. Calcium D3 does not get as well absorbed in gastric bypass patients, and since we don't get good absorption of calcium and vitamin D, patients are prone to have bone problems, and you're talking about osteoporosis down the road. That simply does not happen with the gastric sleeve surgery. Continuing on absorption, we talked about B12 and folate and iron, but some vitamins are specifically not well absorbed in the gastric bypass. That's vitamin A, D, K, and E. That does not happen as much as in the gastric sleeve patient because there's no rerouting of intestine. So there you have it. Those are just a few of the complications that may occur in a gastric bypass patient that simply don't occur in a gastric sleeve patient. Again, I'm not saying that the gastric sleeve is a much better procedure or surgery, because that will depend on your specific scenario and your specific needs. My suggestion is touch base with your bariatric surgeon or his office to help you find out what is best for you. I'm Dr. Alvarez with Endobariatric.com, where we are changing lives one sleeve at a time. Take care and God bless.